Good morning. Good morning and welcome to Palliative Care and Geriatrics Grand Rounds. I'm glad everyone made it in safely with the polar vortex. I'm Vera Dobman, I'm the course director, and it's my pleasure to introduce our guest speaker this morning. Dr. Zaklin will be speaking on one of our most highly requested topics this year that we really wanted to make sure we're able to cover fully. So this is the remix. Dr. Ryan Zaklin is trained in internal medicine, geriatric medicine, integrative medicine, mind-body medicine, and cannabinoid medicine. Bit of an overachiever. He earned his Doctor of Medicine from the University of Virginia and completed his training in internal medicine here at MGH. After serving on faculty at Harvard Medical School, Dr. Zaklin continued working for partners within the Spalding Rehab Network. In addition to his current partner's position, working in skilled nursing facilities, he maintains a private practice in integrative medicine. Within this practice, Dr. Zaklin works together with his patients, partnering his foundation in internal medicine with mind-body medicine, yoga, energy medicine, herbal medicine, cannabis therapeutics, nutrition, and functional medicine to help his patients return to their natural state of balance. He views optimization of the endocannabinoid system via plant medicine and other integrative therapies as essential to achieving this goal. Being an accomplished musician, he has a particular interest in the link between the endocannabinoid system and music. Please join me in welcoming Dr. Zaklin.
Thank you, Dr. Daubman. Can everybody hear me right now? Okay. So I do want to first thank Dr. Daubman and Dr. Jackson, wherever she may be listening, the Department of Palliative Care and Geriatrics for this gracious invitation to speak here in the Ether Dome about the endocannabinoid system and cannabis. And I want to thank everybody who came to hear me in person, those that are listening to it while it's streaming. And I want to give a shout out to my friends and family that I'm going to make watch this ad nauseum once the recording is up on the website. So I just want to first start out and take a moment and appreciate the history of this place, because I think there's a particularly poignant connection that's happening here. So some of you may or may not know, on October 16th, 1846, known as Ether Day, Henry Jacob Bigelow performed what is thought to be, there's a little bit of debate, the first publicly viewed surgery using general anesthesia using ether. Regardless if it was the first, it was one of the first, and this space now represents a historic tipping point. Grounds were broken, both pain management and general anesthesia, an implementation that changed the practice of medicine forever. I believe we are also here amidst another paradigm shift and subsequent advancement of medicine that's going to forever change the way we all practice. With the discovery of the endocannabinoid system elucidated by cannabis and its multifaceted therapeutic potential, we find ourselves uncovering the answers to many lingering questions. My hope is that you will also find yourself similarly inspired to explore, understand, and implement ECS modulation, which is now most easily done with cannabis, in treating your patients so that you too can become a part of this constantly changing but ever promising landscape. And I can promise you, ladies and gentlemen, this is no humbug. So just to get the disclosures out of the way, I have no relationships with industry pertaining to this presentation. I do have a private practice in integrative medicine and cannabis therapeutics, from which I derive some financial compensation. And the objectives of this talk are to understand the importance of the endocannabinoid system, basics of cannabis therapeutics, and appreciate cannabinoid therapy as it pertains to geriatrics and palliative care. So how did I get here and how did I become inspired myself? So it starts for me with integrative medicine. Just a little bit of my history. I have an overactive mind, so therefore I sought out ways to deal with it, and had an attraction to meditation and yoga. It's really starting in undergrad, and it really blossomed into a passion for integrative medicine. I'm conventionally trained, as Dr. Daubman had mentioned. I did my training here. I was on an unofficial mind-body medicine track with the Benson Henry Institute. And as it's evolved, I guess the way that I look at integrative medicine is partnering with the patient using both natural and conventional modalities to help them tap into their illicit or intrinsic ability to heal themselves and achieve that natural state of balance. balance. So I help people achieve balance, and I've worked very hard on achieving balance in my life. So when I learned about the endocannabinoid system, which is the physiological system that we use to maintain balance, I wouldn't really say that a light bulb went off. I would say that an atomic bomb went off. I mean, it was like a paradigm shift completely. I mean, to me, it was like Morpheus, right? In the movie The Matrix, he says, "This is your last chance. After this, there is no turning back. You take the blue pill, the story ends. You wake up in your bed and believe whatever you want to believe. You take the red pill, you stay in Wonderland, and I show you how deep the rabbit hole goes. Remember, all I'm offering is the truth." Well, I felt like I'd taken the green pill. So, I mean, what is the endocannabinoid system? And let's just dive in. It's the system that we use to maintain homeostasis or balance. And it's thought to be involved in sleep, appetite, memory, mood, but it really touches upon all physiological systems that are involved in achieving balance. So that includes all of these: immunity, pain, inflammation, embryo development, stress response, temperature regulation. So let's time out for a quick quiz. Infrequently asked question: what's the most abundant G protein coupled receptor in the central nervous system? Dopamine, serotonin. Come on, physicians in the office, in the audience, you learned about this in medical school, right? The cannabinoid 1 receptor. And right, there's more of these receptors than dopamine and serotonin combined, and I didn't learn about this in medical school. I'm sorry, but that pisses me off. I've been trying to treat patients, and I'm missing a huge piece of the puzzle. So I'm still in the kind of anger stages of grief. I haven't moved out of it completely, but I'm getting there. This is helping, thank you, it's therapeutic. So what's unique about this particular receptor that was identified by Raphael Mechoulam, Israeli scientist? So it's somewhat unique in that it does have a presynaptic location and retrograde signaling, which is not unique to it. But the endocannabinoids in the system itself are particularly unique. And this receptor helps control the tempo of what's going on in the body. So we basically produce these endocannabinoids. The most well-studied ones are 2-AG and anandamide, but there are 130 to 140. Dedi Miri out in Technion University in Israel, that's my resource. He is the world expert on the endocannabinoid system to me. And so whenever I see him, I always go in for the Matrix download on it. And he told me last time, he said 32 receptors involved, 140 cannabinoids. So these neurotransmitters, if you will, are produced on demand by the phospholipid membranes. They're not stored in vesicles. They're synthesized and distributed by these two enzymes. And then they're broken down. Anandamide is broken down by FAAH, and 2-AG is broken down by MAGL. And these are therapeutic targets. That's why I included. But if you notice, they're broken down into arachidonic acid in part. And it's important to look at the distribution of the CB1 and CB2 receptors. So the CB1, the gross oversimplification you'll hear is CB1 is in the central nervous system and CB2 is in the periphery. That's really not the case. There is a bit of a overlap, and you actually do see CB2 receptors in the central nervous system, and you do see CB1 receptors throughout. It's very difficult to get an accurate depiction because we're still figuring this out. The bottom right, you see the CB3 receptor. That's the GPR55. That's not necessarily called the CB3 at this time, but we're kind of moving in that direction. But most importantly, in this slide, I want you to notice one thing. Check out the brainstem. This says none, very few, very few. You know what kind of receptors we do have in the brainstem, in the respiratory centers? Opioid receptors. So the ECS is involved in multiple pathways. It does have selective agonist trafficking. And this slide is just to show you the complexity. You see here, you see here COX pathways. Many of the physiological pathways are involved. There are syndromes such as the clinical endocannabinoid syndrome, as described by Dr. Ethan Russo. This is a syndrome, however, he presents some interesting, he proposes some interesting questions. And if you think about migraines, fibromyalgia, and IBS, if any of you treat any patients with that, are these clearly defined conditions that we really have our heads wrapped around. There are other ECS deficiencies or other conditions that are thought to be associated with ECS deficiencies. But really, the ECS touches upon every one of these organ systems. And I think it's important not only that practitioners and clinicians understand that, but lay people understand that as well. Most lay people have a basic understanding of our human organ systems. The ECS is not an organ system, but it helps control the tempo of what's happening in all these systems. So you have a patient that goes to the gym and they work out, they work on their pecs. They don't call their primary care doctor the next day wondering why their chest is hurting, right? Maybe a week later, they would know, okay, maybe I pulled something. So there's a basic physiological understanding of the musculoskeletal system. If they climb a flight of stairs and they're sweating a little bit and their heart rate's increased, they don't run back down to the ER to see if they had a heart attack. They have a basic understanding of the cardiovascular system. However, blood in the stool, circulatory system is overlapping with the gastrointestinal system. Not supposed to do that. You bet you're getting a call or going to the emergency room, depending on the volume. So what happens when they're just a little imbalanced, just a little famished, if you will? What do they use to tell themselves what's happening? As long as all the T's are crossed and the I's are dotted, I think the ECS is an important story to be able to tell themselves that so that they know that they're safe, they know that they're okay. And it turns out that they're actually already aware of the endocannabinoid system. So the runner's high, there's some, not so much of a debate anymore, but previously attributed to endorphins. Right, you run and you need some analgesia, natural analgesia, so you produce endorphins so that you don't feel the pain from running. Running really shouldn't be that painful. It's really thought that when you're running, the system is stressed, and you do have ECS modulated analgesia, but you're bringing the system back into balance. The system is stressed, there's too much glutamate excitation, and so we crank out anandamide, named after the Sanskrit word for bliss, to calm things down, and afterwards feel a euphoric sensation, not dissimilar from the sensation of a mild intoxication with something that might modulate the ECS, such as cannabis. Many other lifestyles, modifications, and modalities affect the ECS: mind-body interventions, acupuncture, osteopathic manipulation, massage, as I mentioned, exercise. And interestingly enough, many medications use ECS pathways. Acetaminophen uses an indirect CB1 pathway. Did anybody here know that? Anybody here using Tylenol with your patients ever? I want you to get mad. That's the whole point of this. I want you to leave here angry, okay? Natural medications, polyunsaturated fatty acids, increase anandamide and 2-AG. Probiotics, increase gut expression of CB2 receptors. Alcohol, caffeine, chocolate, yay, right? Other herbs. I want you to notice that this is really the first time in this talk that I'm really mentioning cannabis, okay? This is not about cannabis. Talking about cannabis would be like speaking about only diuretics first in relation to cardiology, or only statins. Most fields don't focus on the intervention, they focus on what's going on in the physiology behind it and the cause. So I'm going to get into a little bit of cannabis basics because I think it's necessary just to be on the same page and let you know how I think about it. The basics is that cannabis is not so basic. There's over 400 compounds. It's thought to be up to 500, 144 phytocannabinoids. The most well-studied ones are THC and CBD. I'll get into those a little bit here. There are over 200 terpenes, which are after my own heart, and I will get into those a little bit, and flavonoids, which I'm not going to discuss in this talk. 3 species, Cannabis sativa, Indica ruderalis. You don't have to worry about that, but I want to answer a question that I'm asked all the time right here. So what is hemp? Hemp is Cannabis sativa that has, in the United States, less than 0.3% THC. Okay, so if you were to take a hemp plant and let that THC level go to 0.4%, well, now it's no longer hemp. Now it's still cannabis. It's just Cannabis sativa, okay? So hemp is classified as cannabis that is less than 0.3% THC. And we're going to get back to that and talk about that a little bit when it comes to CBD. So THC, this is the molecule that everybody in the adult use world seems to be obsessed about. It's a partial CB1 and CB2 agonist, but this is the most important part of this slide. It's intoxicating at high doses. THC in and of itself is not intoxicating at any dose. Similar to alcohol, where a sip of wine, you don't feel anything, a little drop of THC is not going to get you high. So we need to kind of get over this. Many of my patients come into my office, they say, I don't want THC, I don't want THC. I say, no, you do want THC, okay? I'm the doctor, let me tell you what you want, okay? But you don't want to feel high, and that's okay, and you don't need to be. The majority of my patients don't feel any intoxication. I like the word intoxication. CBD, so this buzz-free molecule is getting quite the buzz. What I want you to take away from this, it is 100% psychoactive. You'll see everywhere, it's not psychoactive, it's not intoxicating. But how could it treat anxiety? How could it treat seizures crossing the blood-brain barrier and not be psychoactive? Caffeine, chocolate, those are psychoactive, okay? Chocolate and caffeine are probably more intoxicating than CBD, but it is psychoactive, it's just not intoxicating. And I like to go into it a little bit here. So it does minimize the psychoactive effects of THC. It's thought to allosterically modulate the CB1 and CB2 receptor and have some mild antagonistic activity. It also blocks conversion of delta-9 THC to 11-hydroxy-THC, which is a much longer-acting, more psychoactive metabolite. When this is happening, this is when you hear these horror stories in Colorado of I ate the quarter cookie and didn't kick in, and then the other quarter, and then ate the full thing, and then an hour later I was in the emergency room. That's because this builds up in the liver. And very important, it's a potent inhibitor of CYP3A4, okay? So your patients that are out there getting, their CBD at the local Quickie Mart, it is interacting with their medicines. So you need to be aware of that. I like this study here from JAMA in 2017, 84 products from 31 companies, okay? This is important stuff here. 42.85% were under-labeled, right? So we're talking about accurate dosing. There's more in it, great, you're getting more than you bargained for. Fine, only around a third were accurately labeled, but this is what's most interesting to me. THC was detected in up to 21% and up to 6.43 milligrams per milliliter. That is more than I recommend for my cannabis-naive patients. So that means somebody who's buying an online CBD product and taking 10 milligrams of CBD 3 times a day may be taking upwards to 18 milligrams of THC. But it's working fabulous for them, and it might be, right? But I just want you to be aware of what's happening. Less than 0.3% THC. So you can have 300 micrograms of THC in a hemp-derived CBD product. Anybody know any other medications that are derived from plants that be dosed in micrograms? Derived from foxglove, digoxin. 250 micrograms, too much for the geriatric population typically, right? 125 micrograms. What about fentanyl? 50 micrograms will kill many patients, right? So it's important to know what's going on here. It's either the CBD, the microdose of THC, or both of them working in concert that these people, in combination with a placebo response, which doesn't negate it to me as a mind-body doc, but it's important to know what's going on here. So a couple of other cannabinoids that I'll just touch upon briefly. THCA is the acidic precursor of delta-9 THC. It's not intoxicating, but I think this is what, and I want to include these because you'll see some of these on dispensary menus. You'll look and it'll say THCA content or percentage. So when it's in the flower or bud form, it's in THCA acid form. It needs to be heated to 212 degrees and decarboxylated into THC to become psychoactive. This is very interesting because it's thought to be a very potent anti-inflammatory, maybe up at 10 to 20 times more potent than CBD or THC, and it's thought to be as effective as THC in certain populations and some small studies at 10 to 20 or at 1/10 or 1/100th of the dose. So I think we're going to see a lot of THCA, especially the fact that it's not intoxicating. This is what you're going to see coming down the pike. THCV is just another phytocannabinoid. It's not intoxicating in and of itself. It's an appetite suppressant and may help regulate blood sugar. I think we're going to see some THCV products. And CBN is really a breakdown product of THC metabolism. It's mildly sedative. It's not really well studied, but you will see some sleep products that say they contain CBN. I suspect that some of the dispensaries are using some of their older flower that now has CBN in it and recycling some of that, but that's okay. Now we get to talk about terpenes, or I get to talk about terpenes. So terpenes are essentially, a terpene is a chemical structure based on that isoprene molecule. And in plants and animals, they're really, in plants, they're essential oils that give them their odor and flavor, and they're really used to communicate, okay? They're in many ways. Some of them are used as pesticides, natural pesticides. You're actually familiar with a few terpenes. So, linalool, it's calming, relaxing, found in a purple flower called lavender. You're quite familiar with pinene and limonene. If you don't even have to close your eyes, if you imagine being in a pine forest and taking a deep breath in a pine forest and reaching into your pocket and squeezing a lemon rind and smelling it, right? You can even now, as I'm speaking, get a sense of refreshment, being invigorated, right? That the lemon sage body wash that's energizing, right, contains limonene in it. This is a terpene that's of particular interest to me. It's beta-caryophyllene. This one is a selective CB2 agonist. It's the only one that I know of that's a dietary phytocannabinoid, and it is found in black pepper. Let's stop for a moment and think about this, okay? So out of 15,000 plus herbs that are out there and exist, the only one to win out, to take its place at the table in every restaurant in the Western world next to an electrolyte, sodium chloride, was black pepper. Is there a connection between that and the high amount of BCP that targets the CB2 receptors that help with our digestion and help modulate the gut response? Maybe we had some attraction to it and understood that this is good for us. Just a thought. So you take your terpenes, you take your cannabinoids, and you put them all together, you do the hokey pokey, turn yourself around, and you have the entourage effect. I like musical terms, the ensemble effect. So you end up having what are called strains. So let's be clear too, it's not strands, it is strains. It's just a pet peeve of mine when people call them strands. So what's happened here, and you'll see this a lot, is that you can notice indica has wide, shorter leaves, and sativa has taller, thinner leaves, and the plants themselves are indica shorter and bushier, and sativa is longer and taller. That is the phenotype, and you'll hear that that doesn't necessarily equate to chemotype, and it doesn't. However, it's kind of become a hybridized nomenclature that we now use. So if you want a cannabis strain that is going to be sedating or relaxing, you might choose one such as Granddaddy Purple. I know they have silly names, but that Granddaddy Purple has linalool in it and is therefore calming. What if you wanted something that's going to be energizing and invigorating? How about Super Lemon Haze with that limonene that's energizing, right? So that's just giving you the kind of the information that you need to, when you can look at a dispensary menu yourself, you'll now understand. So I'm going to go talk about cannabis therapeutics, and you might think that this slide is depicting that we're embarking on a new horizon. That's not the point of it. The point of it is, before I go on and talk about cannabis as medicine, I need to be sure that if you don't think cannabis is medicine, you might as well think the object in the front is flat and that the object behind it is revolving around it. Because it's a fact that cannabis is medicine, and it's time that we start really implementing this to treat our patients. So I'm going to get into the evidence a little bit, and it's important, right? There is evidence, and there are studies. But we all know that it's federally illegal. We all know that it has not been able to be studied. There are other factors involved. So the studies that have been done by the government have been using, I think, only their one crappy strain that they use, and it's used to prove it that it doesn't work or prove that it's harmful. So those are the bulk of the core of the studies that have initially been done. Now we're getting a lot more research out of Israel, and times are definitely changing. But you also have to remember what I said. Over 400 compounds, 32 receptors, 140 phytocannabinoids. This is not your placebo-controlled randomized trial material. It's not one target and one molecule. There are many molecules and many targets, but that being said, we're still making good headway. So I can get into it. Case study, one of my patients is a 55-year-old male, a former drinker. He had developed peripheral neuropathy. It was excruciatingly painful. He developed it about 7 years ago. Said it was 20 out of 10, felt like something was scratching out of the bottom of his feet, and it kept him up at night. He would sleep in a recliner. His family couldn't stand him because he was just a jerk. Sent him to anger management classes. I don't know if they worked. I'm gonna get back to him. The other patient that I want to talk about is a 77-year-old male with metastatic adenocarcinoma with a neuroendocrine tumor from his treatment that I met that had failure to thrive and cachexia. He had lost 60 pounds over several months, was cachectic, and to say that he was disconcerted, I mean, that's an understatement. He was unable to enjoy his life, especially his wife's cooking. She was a great cook. So I like this systematic review from 2015. It looked at 79 randomized controlled trials, and this came to the conclusion that there is conclusive evidence for cannabis managing chronic pain, nausea, vomiting with chemotherapy, spasticity in MS, and seizures. The National Academies of Sciences, Engineering, and Medicine came out with this document in 2017, and they actually came to the same conclusions after reviewing over 10,000 abstracts. So we can say there is substantial evidence that cannabis is an effective treatment for chronic pain in adults. Substantial evidence. If you're treating chronic pain, I urge you, I mean, I'm biting my tongue by saying you need to be using cannabis. Let's go back to my man over here with the peripheral neuropathy. Started him on tinctures, drops. So tinctures are basically a liquid format. The way that I look at it, there is some buccal absorption, but I don't use them for that. It's more for dose titration. A couple of drops. He moved up to one capsule containing 10 milligrams of CBD and 1 milligram THC that he took twice a day. His neuropathy was gone after one day. Now, it came back, and he had to escalate the dose, and I had to increase the THC, and he's still a little bit of a work in progress. But for several months, he experienced no pain and zero intoxication, 2 milligrams of THC a day. It's actually I think it's actually too little. I think now we're still working on him, but I think he needs more THC. What about chemo-induced nausea, vomiting? Conclusive evidence, but interestingly enough, insufficient evidence to support or refute that cannabinoids are an effective treatment for cancer-associated anorexia cachexia syndrome or anorexia nervosa. Let's go back to my man over here with failure to thrive with cachexia. Started on low-dose tinctures. I mean, I'm talking 2 to 3 drops of a tincture 2 to 3 times a day, a minimal dose. He gained 20 pounds in 2 months, renewed his appreciation of love and food. He enjoyed his wife's cooking again. He enjoyed wings during a football game. He enjoyed. This is the most important slide in this talk. This dying man, instead of withering away and not enjoying what he lived his life for, died a life well lived with a full belly and a happy man with a few drops. How could we withhold that from our patients? So going into the research in a little more depth. So this is Stacy Gruber is leading the charge and is doing some amazing work at McLean in the marijuana investigations for neuroscientific discovery. So she has 2 papers that I consider landmark seminal papers, and I think they will be. So one of them was Splendor in the Grass, where she looked at, for the first time, she looked at medical cannabis patients. And I want to mention that too. Keep in mind, in terms of the evidence, much of the evidence comes from smoked cannabis, and a lot of it are from recreational users or non-guided users, right? So if you were to look at study metoprolol and say, wow, this stuff doesn't work, everybody that takes it, their blood pressure just drops and they die. And you're like, well, how much are they taking? Well, they take 400 milligrams at once. Right? So, I mean, it's dose dependent. Now, going back to this, these were medical cannabis patients, and they actually showed improvement in executive functioning. So, after using cannabis, and interesting, their opioids, antidepressants, mood stabilizers, and benzos were all cut. She did a similar study and looked at medical cannabis patients, and this, to me, is literally mind-blowing. After 1 month, there was increased activity in the cingulate cortex and the frontal lobe in medical cannabis patients, and when she compared them to some previous studies and healthy subjects, they were similar to non-cannabis users that were healthier subjects. So there was suggested that there was some normalization that was happening in these patients using medical cannabis. I find this interesting. In the same study, opioids cut 47.69%. I'm taking that 0.69. Benzos, 46.91%. Antidepressants, 22.35%. And mood stabilizers, 28.57%. You know that patients don't lie about pain going away. You know that they don't request less opioids and less benzodiazepines typically. Let's look at what's going on in Israel. 131 patients, all cancer-related or treatment-related symptoms improved. All. Opioids were reduced in 44%. Antidepressants, anti-anxiety in 33%. Why don't we look at some epidemiological data? Medicare Part D patients, prescription pain medication use was reduced in medical marijuana states, and there were significantly lower state-level opioid overdose mortality rates. I don't understand why the alarms and bells aren't going off and people aren't running towards this. A similar group, I think it was the same group actually, I'm sorry, looked at Medicare prescriptions, and there was almost a 6% in medical reduction in prescriptions in medical marijuana states, and in adult use states, 6%, a little over 6%. What I find interesting though, is that in Massachusetts, in 2017, there was a 4% decrease in opioid-related overdose, down from 2016, fine. But since 2016, there's been a 30% decline in opioid prescriptions, and this is attributed to the Mass PAT system. I mean, which is great, has been an amazing implementation, and definitely has influenced all of us. But I just wonder about that 30% decline. I mean, what's also simultaneously happening here in this state? It's just some food for thought. So let's talk about some safety concerns. Subanalgesic doses of THC and morphine are equally unsuccessful, but together they're actually effective in reducing pain. And adjunctive whole plant cannabis does not have an effect on opioid pharmacokinetics. In the preclinical models, co-administration attenuates tolerance. Look back at those studies. We're cutting the doses in half here. How about the elderly? This is a great study that was in the European Journal of Internal Medicine. They looked at 2,700 patients, geriatric patients, mean age 74.5. Most common indications were pain and cancer. After 6 months, 93.7% reported improvement. Can you please show me those numbers elsewhere for other interventions? 93.7%. Pain reduced from 8 to a 4. Not in all 93% of those. Most common adverse events were dizziness. People describe the intoxication in many different ways. Dizziness is a typical way to describe it. And here we go again. 18% reduced or discontinued opioids. 18%. To me, these numbers are staggering. Just touching upon what happens as we age with the ECS. So we do have CB1 expression that's reduced in brain tissue. G protein coupling is reduced and you have lower 2-AG levels. There is an interesting study where they use low dose THC. It wasn't that low, but they looked in mice, and the short of it is the aged mice, when given THC, performed and had gene expression that looked comparable to the younger mice. So there's some suggestion that our ECS, just as many of our physiological systems, tends to kind of age as we age, if you will, and sometimes needs a little bit of a tune-up. I know something that's a great tune-up. So let's get into safety concerns. Toxicity. This plant, this medicine has a large therapeutic window. Some people respond to microdoses of THC. Some people need thousands of milligrams of THC. But there has, and you'll hear the cannabis enthusiasts say this ad nauseum, but it's really, I mean, it's a golden card to pull. There have been no overdose deaths recorded from cannabis ever. I mean, think about that. Every time I hear that, that's mind-blowing if you let that sink in. Since I've started this talk, I wonder how many people have died from opioid overdoses. So it's essentially not toxic. I'm not saying that it's safe, 100% safe, right? People can do stupid things if they're intoxicated, but as a medication, it's essentially not toxic, and it's less toxic than arsenic. It's less toxic than ibuprofen. I'm sorry to say, it's less toxic than wine. And how about this one? It's less toxic than water. Not that water is necessarily toxic, but I ask you, why do they cover the toilets in some psychiatric institutions? Right? People are wondering what the heck I'm talking about, because you can get psychogenic polydipsia and they'll drink and drink and drink. It's a way to commit suicide. You drop your sodium, you can kill yourself. So you can kill yourself with water. You can drown yourself too. But you can kill yourself with water before you can kill yourself with cannabis. What about cancer risk? So there's moderate evidence of no association with the incidence of lung cancer and head and neck cancer with smoking it. I don't recommend smoking it to my patients. In fact, most of my patients don't even inhale their medicine. They may vaporize the whole flower, and particularly for patients that have absorption issues. But this is, I mean, Donald Tashkin set out to prove it, that it did cause cancer, and his conclusion was that it doesn't. Contraindications, so it does cause low birth weight, so I won't certify pregnant patients. Schizophrenia, or family history of schizophrenia, there is evidence of an association with development of schizophrenia or other psychosis with the highest risk amongst most frequent users. So again, you have to ask yourself, how is this derived? How much were they smoking? What were they using? What was the underlying substrate? But on the safe, conservative side, obviously, I don't certify patients that have schizophrenia or family history of schizophrenia. In terms of immunocompromised patients, I just don't recommend that they inhale their medication, as I don't for most of my patients, but you have to monitor the immunosuppressants. CBD and THC use cytochrome P450. So what about driving? This is a bit of a controversial topic, and I think we have to compare apples to apples. So are we talking about driving while high? Because that's different. Then the answer is no, right? You don't drive when you're drunk, you don't drive when you're high, but do you drive when if you're taking opioids or benzodiazepines? It depends, right? You're advised not to, and I advise my patients to take their THC mostly at night, if they can, and I advise them not to drive on days that they're titrating their medicine, increasing their dose. But they also have some responsibility in this, and they need to not drive if they sense that they're impaired. Usually if they're like, am I impaired? They're probably not. So that's kind of my quick take on cannabis and driving. I should say medical cannabis and driving. So this is not a discovery. This is not something new. It's a rediscovery. I mean, it's been 5,000 years since cannabis has been used. You can see right outside in the historic documents that they were using cannabis as an analgesia before they had general anesthetic. Now, that's not an argument to use it now just because we've always used it, but it's less than a century since it was removed from the US pharmacopoeia, in which pharmaceutical companies were producing pounds of this to make tinctures to treat your grandmother's insomnia, migraines, headaches, belly pain. And now the difference is we understand why it works, and we can begin to take a deeper dive and use it more efficiently. So in terms of medical cannabis, this is what people think is happening. Not in my practice. This is what's happening. Capsules, tinctures, gummies, and never, look, they're squares, not in the shape of bears and things that are attractive to kids. That I don't get at all. You need professional guidance, though, okay? I mean, part of when we look at the evidence thus far, many of these patients have not been guided. Many of them have been overdosing, right? There's no deaths from overdose, but there have been overdoses. In other words, doses that are more than the necessary dose to treat the intended condition being treated. So just a little bit on how I approach it. So I start out with a ratio of 1-to-1 CBD to THC, using the CBD to mitigate the THC side effects. I start with tinctures and drops, and I give a recommended protocol to my patients. I tell them to titrate. What I tell them is, look, I'm gonna give you your first fish, but I'm gonna teach you how to fish as well. And so I tell them to titrate to symptom management or intolerable side effects. One of those intolerable side effects may be financial. There's a large therapeutic window. Some people don't respond to small doses of THC and need large doses, and it's just not financially feasible. I have them, or ask them to calculate their daily dose, their daily milligrams of CBD and THC that they need to manage their condition. And then once they know that, they can take tinctures, gummies, whichever. I mean, there's little subtleties when you're converting from one to another, but this way they know, and they can go. The dispensaries are not homogenized at this time, so they can go to any dispensary and they know how much they need to manage their condition. And I recommend ECS reset breaks, so resetting their receptors. So there's that large therapeutic window. I start out at around 2 milligrams THC to 10, depending if they're cannabis naive or not. 2 would be for cannabis naive. And then I'll match that with 8 to 40 milligrams CBD. I mean, it should be 2 milligrams if you're really doing 1-to-1. And what's the effective dose? So THC, as I mentioned, here's that 300 micrograms that's present in that CBD, that hemp-derived CBD product. Who knows? 2,000 milligrams is the most I've heard from one of my colleagues. And CBD, we don't know. For Epidiolex, it's 2.5 megs per kg, so that's 150 milligrams twice daily for a 60-kilogram individual. That is $50 a day at one of the dispensaries. So I don't really titrate the CBD. It's just, I think, to be honest, I think the effective doses right now are too expensive. All right. Where are we at right now in Massachusetts? So the medical use of marijuana program was an act for the humanitarian medical use of marijuana. Humanitarian. The adult use program was to ensure safe access. So I'm just going to comment briefly on the benefit of having a card. The way I see it, you don't come to me for certification. I mean, you need an ICD-10 code and a computer, and that will qualify a patient for being eligible for medical cannabis, right? I mean, you don't really need providers to be doing that, but that's the system that we have right now. If you have a medical card, though, you don't pay the 20+% sales tax. There are no limitations on the type of products that you can purchase. And you can go to any dispensary in the state of Massachusetts. You don't need an appointment, and you do actually get significant initial discounts. There are 9 qualifying conditions or a debilitating condition determined by your provider. So Massachusetts leaves that last one open. In my practice, I would say the majority of my patients are chronic pain patients. Interesting, chronic pain is not on that list. It is in other states. Chronic pain, insomnia, anxiety, depression, PTSD, peripheral neuropathy, which is also chronic pain. That's what I typically will see, but chronic abdominal pain. But I see all types of patients, and I would say that 90% of my practice is referrals from physicians within the Partners Network. So as of August 31st, there were 59,185 active healthcare provided certifications and 262 registered providers. Let's dive into this in a couple of minutes that I've left as I'm closing out. There are 5.44 million adults in Massachusetts. As of August of 2018, there are only 60,000, roughly 59,000, rather, if you round down, medical marijuana certifications. So only 1% of the adult population in Massachusetts is using medical marijuana. What percent are using benzodiazepines, opioids, antidepressants, and mood stabilizers? I don't know if I can have that data, but I'll have that data next time. 258,000 opioid prescriptions in the second quarter of 2018. I have the opioid data. So that means in that second quarter, only 23.25% of opioid users were using this therapy that could have cut their dose in half, minimize side effects, prevent them, and minimize their risk of an overdose. There are 35,956 physicians in Massachusetts, 6,280 nurse practitioners, 42,236 providers eligible to certify for medical marijuana, and only 0.6% of providers are doing that. To me, that is unacceptable. I don't think there's any question that we're standing here amidst the true paradigm shift in physiology and medicine. We have clear evidence that cannabis, in and of itself, not only manages conditions, and we understand in part why, but has the ability to reduce the necessary dose of many medicines that we're using. Opioids, benzodiazepines, antidepressants, mood stabilizers, over-the-counter analgesics. As a physician, I took what I consider a sacred oath to first do no harm. And now I know what I know. I'm seeing it work in patient after patient, and I cannot help but feel that keeping this generally safe, non-toxic adjunct therapy from my fellow suffering human beings is frankly a crime against humanity. I feel fortunate enough to recognize my role, and I've made a commitment to learn, teach, inspire, and share everything I can about the endocannabinoid system and cannabis. That's why I'm here. So what about you? You've now also taken the green pill. You'll either love me or hate me, but if you're a provider, there's a very good chance your patients are going to thank you. My hope is that you, current and future leaders in your fields, providers who are caring for people that are suffering, will explore this medicine deeper so you can implement it into your practice. The way I see it, I'm playing my role here. I'm doing my job. May I suggest you ask yourself if you're here to stand at the sidelines as a spectator, or if you're willing to also do your job. Thanks for listening. Go Pats.
It's wonderful, Dr. Zaklin. It's hard to get people fired up and angry at 8 a.m., but I think you got it. I want to open it up to questions, and maybe I'll start. I wonder if this will become an increasing issue with patients who are on medical cannabis and are hospitalized. Would you recommend providers using some of the synthetic cannabinoids or temporarily increasing opioids or something else?
Yeah, that's a great question. And I thought about this kind of, the legalities and because we have to get it into hospitals. I haven't really thought about that one. Because what's going to happen is they're going to have a forced ECS reset break, right? Ultimately the answer is we need to get it into hospitals and people need to have it. So, Marinol is synthetic THC in a sesame oil matrix. It's not as effective. You might be able to use that with some CBD products, and that might be an effective approach. I would probably try that. Otherwise what's going to happen, it's just another part of the problem. Patients will have, you do have a withdrawal. It's not life-threatening, but they just may have their, symptoms exacerbated. And depending on the hospitalization, as I said, if it's a week, then they get to reset their endocannabinoid receptors, and they might have a lower dose be more effective when they're done.
I like it. Reframing as an ECS break. Other questions?
What a presentation. You crushed it, man. That's good. I'm getting my next appointment with you next week. So I think great. For resources for the patients, where do they get that? So like somebody comes up to my geriatric patient clinic and then say, okay, go read about it. So ryanzaklinmd.com?
Yeah, that's what I say. That's what I say. Yeah, trusted resources, you can certainly send them my way. And anybody, this is not a plug at all, but I can give you cards and, my website has some resources that they can go to. The Massachusetts website has some resources that they can go to. I actually do think that that Project CBD has some interesting information, but you do have to be careful because there are a lot of enthusiasts out there, and there's a lot of information to, pun intended, weed through.
Awesome. I hope you brought some samples.
Yeah, that was. I forgot that's my joke. Yeah, I didn't bring any samples. Sorry.
Thank you. You mentioned this earlier, but there's an issue of affordability, and that ends up playing out that basically only people with financial resources have access to this medicine. So I'm wondering if you have any suggestions or thoughts or strategies for patients. It sounds like insurance doesn't and won't cover this anytime soon, probably, so.
Yeah, I mean, that's a great question. So most important, this is why we start low and go slow. And that's why I started the 1-to-1 THC to CBD, so that they're not starting out at 4-to-1 or 8-to-1 and ratcheting them both up and becoming too expensive. Sometimes we'll drop the CBD and just use the THC. There are some discounts at dispensaries for certain populations for financial hardship. Veterans get 20% discount. I mean, the reality is that if you start low and go slow, it is a plant and you can grow it in Massachusetts. And you can, I mean, this is not the answer for everybody, but a small subset, you can make your own medicine. You can make tinctures fairly easily. So there is making your own. But again, I mean, I think it is part of the issue. However, in states that have had medical cannabis and recreational cannabis for longer, we are seeing those prices drop down considerably.
Other questions?
Thank you, Ryan, so much for coming. I have a couple questions. One is how to think about in palliative care where we may have people in our outpatient clinic who are on hundreds and hundreds of milligrams of opioids, right? So the worry that I have had is really under twofold. One is it may very well decrease their opioid use. It also may not, depending upon how severe their cancer pain syndrome is. And how do we think about that, and what do we know about safety in that? Because our population often is different. These are not people who are on 10, 20 milligrams of OxyContin a day. They're on hundreds of milligrams of either methadone or oxycodone. So that's one question. The other question for me is, I think in our population, I don't worry about sending my patients to you, but I do worry about where else they go. And I do worry about having some random person who doesn't understand the nuances certify, and then they go to a dispensary who, I feel like sometimes part of the issue is people are like, you're just not on the cutting edge. I'm like, dude, I just want to be safe. Right? And so this is not a moral issue for me. This is a safety issue. And if there are Ryan Zaklins all over who I can send my patients to, who I know are going to go low and slow, I don't worry. But I actually don't feel safe saying to my patient who's on 400 milligrams of OxyContin, go get certified by random Joe Schmo and go to the dispensary. So thoughts about those two questions?
Yeah, thank you, Dr. Jackson. There's only one Ryan Zaklin, just to answer that point. No, those are great points. So in terms of the high-dose opioids, I had mentioned earlier, cannabis doesn't affect the pharmacodynamics, and so pharmacokinetics, excuse me. So, you know, I think, again, it's starting low and going slow. I mean, I think you're looking at that. So with a patient that's on high-dose opioids, I would just start them on 1 drop twice a day of a tincture and tell them to wait a few days and then go to 2 drops and really, really taper that out and prolong. I mean, I would think that the concern would be more side effects. Yeah. Yeah. But they don't, so it's not the same though. So it's, now alcohol and cannabis, that they do exacerbate each other rather, but it's not the same as opioids and alcohol by any stretch of the means. And again, with little drops, you're talking about sub-intoxicating doses. So that would be my answer to the first question. The second question is a great, great question. And I'm glad you brought that up because I did forget to mention, right? So you mentioned the dispensaries. Yes, please, please, please do not send your patient to a mill to get a certification and then have them go to the bud tender who just lost their job at EMS and now is standing behind the counter at the dispensary, and have your patient with Parkinson's or MS or that's on however many medications ask the 22-year-old stoner what they should do to take to manage their condition. You want to know what tastes good and what's going to get you super high? That's perfect, right? But in terms of managing medicine, absolutely not. And this is part of the problem, and this is why I'm here. The only thing I can say is I'm right here. You know how to reach me. And there are some of us. There are a few of us out there, and we're just here just trying to stand on the cutting edge and not fall off and hope that that people join us. I mean, I think this is part of the problem. You need professional guidance. And so what would be and I've thought about this. So how big could this get? You'd have to have dosing protocols. It's not, I don't want to take anything away from myself, but it's not rocket science, okay? Right? I mean, you do have to have experience, and there are higher levels in terms of when patients come back and what should we do now, and should we use a salve for this, or should we increase the CBD or add some THCA, or does it I mean, so there's definitely some nuance, but to start them out and to monitor them, it's not that I could teach you how to do that. Let's put it this way. And I think, that's the goal. And that's my goal, and that's the only answer I really have is I hope that I can help train more and more people to accept this medicine so that you're not telling your patients, I'm sorry, I just don't know, it's just not safe and I'm not comfortable with it.
We'll make sure we open it up to any questions at our remote sites. Barring no questions there.
Hi. I have a question about the skilled nursing home setting. I work in several different facilities, and I've had a lot of family members seeing the research out of McLean, or there are patients there and they're being transferred out. Their dementia behaviors. Families are really pro marijuana use for the dementia behaviors. And I'm finding a lot of resistance in the skilled nursing homes because they don't find that it's a safe thing to keep in their cart and do a med count. How would you recommend these long-term care patients getting access?
I'm getting all the questions. This is something, again, that I'm working on. So I work in skilled nursing facilities and nursing homes. The question really is how do we get this into nursing homes? The problem is federally illegal, right? It's not medicine, according to the federal government. So nursing homes are federally funded. Now, one of my nursing homes has a policy. However, the policy is that the patient can only administer it themselves, or a family member can administer it. What demented patient is giving themselves 2 drops of a tincture a couple times a day? I wish I had an answer for you, and I hope that next year I will, or the year after I will, and say, well, this is what we're doing. It needs to be, the short of it is, it needs to be probably rescheduled. It needs to be rescheduled. And so until that happens, there's an element of hands being tied. There are, I think, 2 nursing homes in the country that allow cannabis, but they're putting their necks out on the line. These places have a hard time making their ends meet as is. And so, unfortunately, I think what's going to have to happen is we're going to have providers demanding it and patients demanding it, and then eventually we'll make some headway.
Thank you so much, Dr. Zaklin. We'll pause there for the sake of time. Thank you.
All right, thank you very much.